laparoscopic ostomy in children with coliacal cyst.
Dear Chairman, ladies and gentlemen, good morning. Laparoscopic hepaticojejunostomy became popular for treatment of coliacal cyst in China. Like open surgery, the biliary obstruction is one of the most common complications after laparoscopic hepaticojejunostomy. The aim of our study to investigate the etiology of post-laparoscopic hepaticojejunostomy biliary stenosis and to evaluate the safety of redo laparoscopic hepaticojejunostomy or ductoplasty for treatment of such a case. Since January 2006, 30 patients with PLHBS were referred to our hospital from other centers, age around 7.15 years old. Duration since the primary laparoscopic approach from 1 month to 7 years. 16 patients suffer from the recurrent jaundice. All the patients with the symptoms of intermittent fever, abdominal pain, or abnormal liver functions. All the patients were treated by redo laparoscopic hepaticojejunostomy or ductoplasty. No conversions, mean operative time 1.70 hours. Stricture diameter was 0.17 centimeters. Proximal dilated diameter 2.5 centimeters. The stone clearance were performed in 20 cases, and 17 patients suffer from the grade 1 to grade 4 liver fibrosis by pathological examination. Result. The anastomotic stricture were found in 14 cases that take up about 46% of the patients. In 9 cases, the obstruction was above the original anastomosis. In 7 patients, the obstruction was caused by a aberrant hepatic artery in front of the common hepatic duct. This slide shows the before surgery, the intrahepatic duct was not dilated. After surgery, you see the intrahepatic duct dilated proximal to the anastomosis. In the operation, it was found the anastomosis was stricture, so it was excised and the stone was removed from the intrahepatic duct. In this case, you see before the operation, the right and the left hepatic duct was dilated. After operation, you can see the stricture at the opening of the left and the right hepatic duct. The anastomosis far away from the stricture of the intrahepatic duct. In the operation, the right hepatiductoplasty and the left hepatiductoplasty was performed to form the large common opening. In such case, you can see the stricture just in the middle of the common hepatic duct. In the operation, it was found the aberrant right hepatic artery ran across in front of the common hepatic duct. Then anastomosis was divided. The common hepatic duct was fully mobilized and elevated in front of the right hepatic artery. The anastomosis was performed in front of the right hepatic artery. All the patients had been followed up from 4 months to 105 months. No recurrence of the stenosis, no bileak, no cholangitis. The liver function resolved to normal at 3 months after operation. Ladies and gentlemen, our first conclusion is post-laparoscopic biliary stenosis can be caused by anastomotic stenosis, and so the intrahepatic duct stricture, and by aberrant right hepatic artery. These complications can be prevented by improvement of the skills and the knowledge. Early surgical correction for the stenosis is needed to avoid secondary liver damage. This complication could be effectively and safely corrected by redo laparoscopic hepaticojejunostomy and ductoplasty, because the adhesion was minor after primary laparoscopic hepaticojejunostomy. Thank you for your attention.
Questions?
Long, thank you very much for showing the nice data. I think stricture can occur due to preoperative inflammation in the common hepatic duct rather than technique. I mean, if the inflammation is severe in the common hepatic duct at the time of the cystic excision, and the stenosis can occur after operation. So I compare the adult cortical cyst and the pediatric cortical cyst. In the adult cortical cyst, in the inflammation of the common hepatic duct is much severe than pediatric cases. So post-operative stricture ratio is much higher compared to pediatric groups. Do you think, have you checked the histology of the common hepatic duct in the patient who had a post-operative anastomotic stenosis?
Yes, you are right. You are right. Because ideally, from my team experience, no stricture occurred in nearly 800 cases. So I think maybe, because I made the anastomosis that very higher, just over beyond the inflammation segment. So I agree with you.
And I also had a same complication due to aberrant hepatic artery, and aberrant artery was above the anastomosis, and then leading to the stone formation due to compression of the common hepatic duct post-operatively. Thank you.
Yeah, thank you. Come on.
Thank you for showing your great work. My question to you, it looked like there's a lot of intrahepatic duct dilatation. Do you consider transhepatic stent placement for some of these patients?
Sorry.
Do you consider place transhepatic stents on some of this patient as opposed to reoperating?
Oh yeah. You're very nice questions. Before we started the laparoscopic hepaticojejunostomy, in open surgery, we made a comparison study between the stent and the non-stent stent. No different between the two groups. So many years ago, we gave up stent to prevent the stricture. So in our series, we didn't use the stent. Thank you for your question.
I have a question. You suggested to redo surgery after for the stenosis. So when do you think is the best time? How early is early?
How early?
For the redo surgery?
Oh yeah.
Like the length of time that you have to wait to reoperate?
Yeah.
What's the best time?
Oh yeah. In my opinion, if the patient with the symptoms like abdomen pain, abnormal liver function, or jaundice, it's the time, it's the indication for redo.
So whenever the symptoms is there.
Yeah, as early as possible.
The second question is, would you send the choledochal cyst frozen to the pathology to make sure that there is no inflammation to prevent of like a stenosis?
Yeah, for every cases, we made the pathological examination. But after operation, we didn't get a biopsy during the operation to decide which level should be
Okay, because
performed.
you wouldn't know.
Yes, only by
the
observation.
eye. Okay,
Yeah,
thank you.
I have another question. Do you think that, particularly in older patients, percutaneous balloon dilatation could be the first line of the treatment in these cases, and only in cases of failure, redo or laparoscopic procedure can be performed? What do you think about it?
Yeah, because the primary operation is a laparoscopic approach. So such a complication we tried in the same way as laparoscopic approach. Yeah. It's suitable. Yeah.
Thank you.
Thank you.
Okay,
Thank you.
thank you.